All right, so we've got the process. There's some people that have taken some ICE courses, right? The process, does that sound familiar? So the process we're talking about is the evaluation process. Day one with your patients. Now, just to be clear, the evaluation does not end day one, right? We don't use all our PT brain, do great assessments, and then walk away and never do another assessment for our patient, right? Ideally, it's an ongoing process. This lecture is going to focus on day one, though, how to do it really well, some things you want to keep in mind for older adults specifically, based on their perspective, their experiences, their goals, right? With lots of different treatment patterns, like, oh, I got a total knee, I got a total knee program. Oh, I got a shoulder pain patient, nondescript, arthritis, here's my shoulder program, right? We tend to get in ruts. And this can happen with treating older adults too, where it's like, older adults, all right, it's back pain or it's gait. And I've got a program for that. And I know regardless of what we talk about, I'm gonna give them that sheet of paper. Okay, we've all probably been there at some point, right? But I'm gonna give you tips on having the best evaluation process, gathering the information that's the most meaningful for your patients, and how to put that into a great action plan so that you guys can both have a lot of fun versus, we'll try this and see if it works, right? We can do better than that. So we're gonna talk about the steps. So the process, we break this down into a few different sections. One is the subjective, right? Stuff we ask our patients. We've got our physical exam, what tests and measures, outcome measures we choose, which ones we don't choose, things to consider about when you want to do that, when you don't, how to share the news of our findings, right? If we've chosen our outcome measures wisely, they're right in line with what our patient wants and what we want for our patients, hopefully. Everyone's in the same alignment. And because outcome measures for older adults are very powerful and we have lots of research, we can almost use that like a crystal ball to predict the future, right? Some of our outcome measures are not very strong in the world of physical therapy. Anyone familiar with the functional movement system? All right, we like to dog it. It's got some value, right? Regional interdependence, leaning in, learning to coach, looking at movement. Does it predict injuries? No, that's what it was designed to do. It doesn't do that. In the older adult world, we're gonna show you, we have got tools that can almost predict the future for our patients. But how we talk about it is very important. Words we want to use, words we don't want to use. We've also got what things to do for trial treatment, and then how we're going to talk about the plan of care, the journey to reach those goals. Sound good? No one ran screaming out of the room, so I guess you're on board. Yeah? All right, here we go. Seen this slide before, right? That handout HEP. I looked at their age, I looked at their medical conditions, I looked at the diagnosis. I got this. I got a handout for that, right? No, we're gonna assess strength, right? Just like you guys assess your strength. Sometime, maybe for the first time. Like for some of you guys, it was the first time doing a deadlift and getting an idea of what your actual capacity is. A lot of the older adults we treat maybe have never had that experience before either. No one's ever looked to see what they can actually do and make a plan based on it. But I tell you what, as far as things you can do to set yourself up for success, day one, the bar is so low for a lot of our older adults. That's not a good thing, but it's a bar you could trip over, right? Because these older adult patients, they've had decades of people not listening to them, spouting off 16-syllable words like non-diabetic, idiopathic, peripheral neuropathy. Okay, I practiced that all night so I could say it correctly for you, right? Your patients are like, what in the world is that? Degenerative disc disease, right? Nocebos, noxious words that strike fear into the hearts of our patients. But those are things we document, right? There's a place for those words. It's a good words to use to communicate. with our colleagues, maybe not good words to share with our patients. They may just create fear or sound just kind of scary, right? How long is the average general practitioner's visit with a patient? The actual interaction with the doctor you came to see?
10 minutes.
About two on average. Maybe your patient waited for 3 hours. Maybe they spent 6 months sitting on this problem until they finally decided they were going to go talk to someone about it. Someone else took their subjective, and they get less than 2 minutes of interaction. That's what a lot of our older adult patients are used to, right? Not being taken seriously, rushed visits, unanswered questions, and then when they get answers, sometimes they're things like, "You're old, what do you expect? You hurt? Okay, yeah, how old are you?" I've had multiple patients tell me stories like that. Makes me a little bit sick, because yeah, you can see some things be more prominent as we age, but that's not an answer, right? Falling does not happen to everyone who gets older. Someone's coming in for knee pain. Well, you're 75 years old. So is this knee. Why isn't that one hurt? You know, there are reasons. Probably one of the saddest ones I heard, there was a gentleman I was seeing who was about 75 years old, and he was actually being seen for his back, which luckily the medical system had not worked their magic on him to scare him to death about that. But he saw an orthopedic surgeon who told him that knee's going to be better when you're in a box. Yeah, that's the box he was talking about, like dead. Like, I can't fix it surgically, there's nothing you can do, I'm sorry, live with it. Right? We need to keep this in mind when we're working with older adults. They've had some really rough interactions. And if the past is going to dictate the future, they're probably expecting more of that, right? So just listening, eye contact, repeating back things that they shared with us, you are going to set yourself so far ahead of everyone else they've interacted with, okay? Not saying that's okay, but it's really not that hard to do a better job than what they're used to. So there are some pitfalls sometimes working with older adults. Not everyone, okay? I'm not going to generalize all older adults, but who has walked in to an evaluation for an older adult who's maybe had chronic back pain, and you sit down with them and you say, "When did this all start?" What happens after that question? Back in 1965, after my football injury, you're like, "Wait, how old were you?" You know, and then 30 minutes later, we're 6 decades ahead. It's like, all right, now we're up to the present. So to avoid that pitfall, we highly recommend the symptom behavior model to start asking about onset of symptoms, how long they last, get that pertinent information. I'm not saying don't ask them their story, don't get to know them, do it later, do it during intervention. Get that story, value that person. Those things, those beliefs they share with you in those stories, those can be really helpful and give you an idea into the history. But for the beginning part of this evaluation process, skip the bar stool stories, right? For the beginning. Save them for later. Get to know them, okay? But not at the beginning. We want to know, when do your symptoms come on? Whether we're talking about balance, when do you lose your balance? Is there a trend? Is this only happening at night or in the morning? Is this happening in a busy environment? When does your back pain occur? Where do you feel it? Once it starts, how long does it take for it to get better? Those are the types of questions that are going to lead our interventions. They're also going to let us know how far we can push this person. Patient that has a really hot, easily inflamed lumbar radiculopathy, they're like, "Man, when I do this one movement and it kicks on, it takes days to get better." Are you going to be a little more cautious about that person, or the person who says, "I've had this for 40 years, I don't love it, I've never had PT, I live my life anyway. Like, this doesn't really get in the way. I don't like it, but it doesn't get in the way," right? Those are two different irritability models, very high and very low. That's gonna help you figure out how you're gonna spend your time on that first day. This is a great quote by Jeff Moore to summarize that. If all those words made no sense, these are much smarter, simpler words, okay? Don't over-examine the irritable. Don't under-examine the non-irritable, right? So let that irritability be your guide. There's gonna be times you're gonna see a patient where you're like, oh, it didn't get to this, this, and this. If I'd known this was gonna happen, I wish I'd only tested these two things. These are the ones that were the most important. Has anyone else been there, or is it just me? Right? It's like, dang it, I didn't prioritize these well. Paying close attention to that part is really gonna help. So gaining perspective from our patients, we can definitely get that from a subjective history. Sometimes it can be nice to use tools like the activity-specific balance scale, Falls efficacy scale. Those give the patient an ability to rate their own perception of their ability, their safety. Is anyone using the ABC? Yeah, anybody using the FES? Use your other hand if it's FES. No? Okay. So it gives an idea of how confident our older adults are in doing different activities. The second one uses the F word, and I am not a fan of using the F word with older adults. What are you guys looking at me like that? Falls? Yeah, falls? Okay, cool. I won't use that next time. Better joke next time. Okay. There's a courtesy laugh. Boom, got it. Okay, so the patient-specific functional scale is even better when you want to dial it in. When you look at those outcome measures and you're like, all right, they're not going up and down the escalator. Like, if you grew up in my area in Kentucky, like, there ain't nothing around. We don't have to worry about escalators, okay? If that's not gonna capture the activities they're describing to you, the patient-specific functional scale, they get to write it in. They get to tell you. This is a great window into what's actually important to them. Cool? So if you're not using those, look through them. We've got links in the resources. It's easy to just Google these and pull them up. But really nice to have those handy. If you don't have them printed out, if you're on electronic EMRs, you can pull up PDFs. Or if you forget, you can just Google it and pull it up. But those can give you a lot of insights into your patient's perception of their ability. But sometimes it's not always accurate, right? Sometimes their perception is way off, right? We know physically based on what they're telling us, what they're showing us, that they can do way more, or maybe they think they can do more than they shouldn't, than they should, right? So sometimes our patients with mild cognitive impairments, patients that have had traumatic brain injuries or dementia, sometimes they think they're just as functionally able as they were 20, 30 years ago. So just don't want to paint the picture that it only goes one direction or the other. You can get lack of perception with reality on either ends with these scales. So just think about that as you're getting to know your patients in the subjective history. But we know fear has a huge impact on our patients and how they function. Christina already kind of set this up for us, but this isn't just a hypothesis. We know fear impacts their movement. So this is a really busy slide, okay? So I'm gonna walk you through it because this is a super cool study. So there are two groups of older adults here. We've got older adults that are low risk of falling, have not experienced a fall, and then over here, we've got high risk of fallers. Now when we look at this axis here, we've got number of gaze fixations, where their eyes are scanning, okay? And then down here, we've got the duration of time that they're looking at that object. So we've got two sets of older adults, high fear, high risk of falling, history of falling, and then we've got low risk, no history of falling. They're going through an obstacle course. They have to go onto this target and then step over two obstacles. So these little numbers, those are the order and the locations of where their eyes looked. What do you notice about these numbers on this path versus this one?
Moving ahead.
Yes! And this group is not. If an older adult is traversing an obstacle course or real life and there's stuff in the way, and they're not scanning the environment, what could happen? Yeah. So functionally, these groups had the same ability level. The thing that was different was fear. Fear's on board. Look at how many times they look at just the obstacle and how many times they scan into the future. 1, 2, 3, 4, 5. So the high-risk followers are spending much more time looking at these, fixating right here. And then the low risk, man, they're scanning. Look at where point 3 is. 4 is all the way at the end, and then they're coming back through. So what they found, because the fixations were so long and so clustered here, they didn't have a good map of what they were traversing, and they spent so much time looking here, it actually hurt their accuracy of how they're moving. And remember, they've got the same physical abilities in both groups, almost identical, except for their fear. So this is a really busy, slide, okay? But the main things I want to point out, this is kind of a theoretical understanding. They're trying to put some sense together for what they found from the study. They found that the fall-related anxiety here leads to an internal focus of attention. And what that did was that increased stiffening postures. Stiffening postures are really helpful in co-contraction of the front and back side of your calves, because where's our first line of defense for our balance? What strategy? Ankle, right? So their first line of defense, the fear is taken over. They've got higher co-contraction at their ankles, shorter step length before they even start. They're focused on, can I move? Can I get my foot there? The group 2, the low risk followers, man, they didn't have any hesitation. They're scanning the entire room and then moving forward, right? Huge impact of fear. They didn't have a correct motor pattern and spatial awareness of what was in front of them. So just things to keep in mind, right? When we see our patients that are high risk of falling and they're looking down, right? This is some insight into that. If you see that, there are lots of things to test. Don't jump to any assumptions, okay? That's the whole point of the lecture. But things to consider. Is fear on board? Would an outcome measure be helpful for me to understand, maybe if they're not super forthcoming with information? So, more ways to gain perspective of patients. These questions, I guarantee 90% of the older adults you interact with have never heard. Providers don't ask them these things because they don't have time for the answers. We have the luxury, most of us, at least in an evaluation, to spend some time listening. And we want to make sure those questions are very deliberate. So what do you think's going on? Sometimes our patients will tell us what our providers told them. Well, the doctor said I've got this. Well, okay, cool. What do you think? Sometimes that's gold. They feel like they've got permission to tell you what they really think. And also you can ask them what you think is going to work. That also gives you an insight into their beliefs, what they think is going to work. Now, I'll be the first to tell you, I do not like using ultrasound. After I read this study that said it doesn't matter whether it's plugged in or not, right? I was like, okay, cool. So what are we educating them on while we're doing it? There is a treatment effect, whether it's placebo or not, right? But if I've got a patient that says, the only thing that has ever gotten me better is ultrasound, and you're just chucking deadlifts at them, man, I'll let them do some ultrasound, but I'm also gonna make them deadlift, right? And whether they wanna believe it's ultrasound or not, I don't really care as long as they get better. I'll let them believe what they need to believe to feel better, right? It's a hurdle, it's a gut check, especially when you're reading the research and oh no, this doesn't work, I can't believe I'm wasting my time on this. But the patient doesn't believe that. So getting an insight into what they believe. This will knock them for a loop. This is a great trick to use that last question. Let me see if I understand you correctly. How many people have to document point of service while they're working with patients, right? Now that is awesome if you can type and look at them, but I guarantee if you're typing while they're talking, they're wondering, are they really listening? Are they really listening? Boom, you got the silver bullet right there. You can show them you were listening, right? If you can do that and multitask, great. Super efficient, prove it to them. It sounds like when this happens, you experience a loss of balance. And it sounds like there's a trend that it only happens under these conditions, right? Because we want that to lead into our outcome measures. Based on the information you gave me, I think I know what we need to test to figure out what's going on here. And more importantly than that, I can help you with it. Boom, they're sold, right? They're sold. So this can vary wildly. These patients have come here because of a problem, because of back pain, because they're unsteady on their feet. But to do what? What is the so what factor for the patient? What successful aging look like to you? I don't recommend that specific question. You can try it. Some patients may be very perceptive and may think like that, but it's like, if I could wave a magic wand and make your back pain go away, what would you do differently today? What have you been putting off you're now going to do? Dig a little bit deeper. Figure out the why. Figure out the why. Great quote. Dr. Atul Gawande, is anyone familiar with him? Checklist Manifesto. He's an author, he's a surgeon, he's a researcher, and he's also written some very highly esteemed books on the medical system, on aging, how to live your life, and the use of checklists of all things. But this is a great quote. We're gonna show you guys so many cool techniques beyond deadlifts that you're gonna use, but this is something we've got to keep framed up. The patient's goals don't always line up with the provider's goals. Our goal is safety, survival, health, while their goal may be to read a book in silence. We're gonna be all hopped up on deadlifts and carries and power training and jumping, but that might be our patient's goal. They're like, really, I just wish I could get up, get dressed, and go read my book or sit comfortably in my recliner and watch my stories, right? And we have to honor that. We have to honor that. He goes on to say, and that's why you can gradually lose some function, have some health issues along the way, yet have great satisfaction in life. So just keep in mind, we want to leverage these tools to do what our patients actually want. So when we're trying to figure out how to help our patients age successfully, this can be broken down into 3 major theories, or a theory broken into 3 parts. So the first thing is selecting meaningful goals. Meaningful goals to us, meaningful goals to our insurance providers, or meaningful goals into the patients. We gotta set some goals that insurance is like, okay, cool, I get it, this is important. But we wanna make sure that we're filtering those goals through what our patients actually want. Optimizing, we do this really well in physical therapy, I think. We wanna fix it. We don't wanna give you a tool that helps you do it, we wanna fix it, right? We wanna optimize the systems we need to get them to the goals they actually want to reach. Pretty straightforward. Compensation, this is the one that always makes me cringe a little bit. Sometimes we have to compensate. Sometimes to reach the goal in the timeline needed for the patient, or to build rapport, or to build trust, or to show them that we're on their team, sometimes we need to compensate. Sometimes our timelines are not, we don't have 30 years to do this. Sometimes our timelines are much more narrow. So to give you an example, I had a patient who had a terminal diagnosis. I was going to cover in a skilled nursing facility. I was just a weekend guy, right? So they leave you little notes about these patients. Things like, does not participate with therapy, needs lots of encouragement, go back several times. Like setting you up for like, okay, there's some type of disconnect here. So I go meet this patient. She was very pleasant, very pleasant. And I was like, how's it going in therapy? Because I knew like clearly things weren't going well. And she was like, it's awful. I hate it here. I don't want to do any of this stuff. I don't know why I'm here. I was like, okay, well, what are your goals? Like, they sent you here for a reason. She was like, I just want to die. And I was like, goal, right? How do I help this patient die? That's my goal. And I realized she's got a terminal diagnosis. She doesn't have a whole lot of time to live. She's been shuffled from acute care to the ICU, to acute care, to skilled nursing, to acute care, to rehab, to subacute, like whoever's gonna take her. She's been tossed around, and she just wants to die in peace. Like, we've got the right to live, and we've got the right to die, right? So I found out for her, she wanted to die at home. I was like, great, let's get you out of here. This is an awful place to die. You don't want to die here. You don't want your last memories to be here. I will do whatever it takes to help you get home so you can die in peace with your family around, in your comfortable chair, on your couch. However that looks for you, let's make a plan to get you there. She kicked ass in PT that day. She crushed it, right? Because she knew I was on her team. It took a little bit of thinking. I'm not gonna act like I didn't get super sweaty and like have to think on that for a little bit. But we can be great assets to our patients. So we're gonna move on into the examination, what we're gonna test. So hopefully by now we've got a really clear picture why the patient came to us, what they would like to do, and we should have a pretty good idea where their deficits are or what type of tools we want to use to figure it out. Like, where are their deficits I can help with? The best way to do that is asterisk signs or comparable signs. Is that familiar to at least a few people? Like, that's the thing, like the classic example, and you can actually see it in this picture, is like, oh, shoulder impingement. Oh, that's it. That's my pain, right? What are you gonna do that visit to make some change towards that goal? Okay, that's a really simple, easy one. You can usually make meaningful change. Sometimes that's not the case with older adults. Maybe you're breaking that down into a step towards their goals. I did not reach my patient's goal in the skilled nursing facility that day, but we took a step towards it, right? We made meaningful goals. We did meaningful therapy based on her goals, right? So whatever way we can identify that thing we can test and correlate it with their goals, that's where we want to show our value. So screens and outcome measures are a great way to do that. We can identify what patients are at risk of, right? When we've got the FMS and we shake it to figure out if someone is at risk for an injury, it's like shaking the magic 8 ball, right? It's like, I don't know, I'm just gonna shake it and hopefully it'll tell me what I wanna know. When we've got geriatric outcome measures, there are billions of dollars that have been spent to do the research to figure out what happens to people when they score X, Y, or Z. Normative values. This screen shows us you are at risk of this, or we're ruling out that, right? That's a big thing. It can also give us a really good idea. Christina spent a lot of time talking to us about frailty and the risk of our patients becoming frail and moving down in that trajectory, right? That is not the slope you want to be on, right? So another way to think about that is we're looking at our functional reserve curve. I didn't mean to rhyme, but I did. So we're looking at their physical ability. What's this red line? You can say it, it's not a trick. Independence. Okay. So one of the big things that we preach in this course, and you will hear in every ICE course, is about the importance of physical activity. Now, if this is patient 1 and this is patient 2, which one needs physical activity more?
Both.
They both do, correct. Who's going to be more at risk if this person stops exercising or this person stops exercising? Because what's going to happen to this person? They are so close to that red line that takes away their independence. They have no margin. You can think about this kind of like a bank account. If your bank account, like you've got just enough money to pay all your bills, and then you get into a car accident and have medical bills, or you get a flat tire, what's gonna happen to your bank account? You're in the red, right? It's the same way with physical reserve. The more reserve, actually the less important. We're not saying we don't want everyone to exercise, we do. But it's even more important for our patients that are slipping down with less functional reserve, right? Into those geriatric syndromes, becoming frail. Another great quote from Jeff Moore to clarify all those words simply said, "We manage symptoms to maximize function." I don't know about you guys, it's hard to get super excited about just reducing someone's shoulder pain. It is really exciting to think I can help change the trajectory of their life and this person for 30 years from now. I can help them stay out of the hospital. I can help them be around to play with their grandkids. Like, that gives me chills, guys. How about you? Is that exciting? Like, we can do so much more. So some things to keep in mind with outcome measures, we want to use the tools that we have and dial them in based on the patient's goals to confirm or deny our theories we've made during our subjective portion. A great quote from Dr. Tim Fearon, "As much as necessary, as little as possible," right? Because there are other things we want to do on the evaluation process other than just run screen after screen after screen. I did this so horribly wrong as a new grad when I came out of school. You give me that EMR with all those empty boxes, my job is to fill those boxes. If that joint can move in that direction, I'm gonna test it. Whether it matters or not, I'm gonna test it because I'm gonna do my job by filling in the box. We can be so much more dialed in. So we need to demonstrate value to patients, to our payer, but we also need to keep in mind, if we use this small collection of outcome measures that we try to use on everyone, people are gonna ceiling them out. I had this happen last week. I had an 84-year-old come in, her diagnosis was ataxia, and I was like, great, I'm gonna run an SPBB on her, and I'm gonna figure out exactly what I need to know. And it's got just a few balance tests, and it's got a 5-time sit to stand in it. She did her 5-time sit to stand in 8 seconds. Next time we do our 30-second sit to stand, watch the clock. We've got one up there. 8 seconds. Totally threw me for a loop. Luckily, I practiced some higher level stuff and was able to recover from there, but she crushed it. She ceilinged it out. Full points. Was that meaningless information? No. I now know more things about her, but it sure didn't tell me what I needed to work on. I knew what I didn't need to work on, basically. So other screening measures, heart rate and blood pressure. Are you guys checking this with your older adults? Yeah? Cool. Great thing to be doing. So many asymptomatic patients with high blood pressure. The statistics are that you can prevent 80% of strokes by screening blood pressure. Asymptomatics, right? I had, when I was on the neuro unit, I had someone come in their 30s, post-stroke. They'd been to the doctor, didn't want to take their hypertension meds, 200 over 112. Preventable. Good things to be using. You can also use the heart rate to just track their response on these outcome measures or on your home exercise program to demonstrate progress, right? Their home program on day 1, what the resting heart rate is, how high it goes up at the end, or how long it takes to get back to their resting, right? That's an easy outcome measure, but if you have no baseline, you can't leverage it. Here's another easy one too. Orthostatic hypotension. Has anyone had any patients with this? Feels super debilitating, right? They change position and what happens? Yeah, they can go down. We can screen for this. They may have gone to a doctor for years and said, I feel dizzy. And that's where the conversation ended. All right, let's put you on some medications for dizziness. Or they've been on the same medication so long, they're impacting them differently. Gut motility in our older adults slows down. Those same dosages of medications can have an increased effect as time goes on, right? For like dropping their blood pressure. So maybe what was appropriate 30 years ago is no longer appropriate anymore. So it could be a quick medication change that helps. But this test, this is an option for you for testing hypostatics. So we've got 5 minutes lying down, a minute standing, and 1 minute standing, and then 3 minutes standing after, and checking for that drop in systolic of 20 points or 10 points on the diastolic, on the bottom number. This may be something that no other provider is going to take the time to do that can really show value to your older adult patients. Oh, this is my favorite. Gait speed. Gait speed is so helpful. A good gait speed is like a good midstream urine sample. You want to clear the area. You don't want anything at the beginning, and you don't want anything at the end. You just want to capture the middle, right? Yeah.
Call her Casey Lockett over here.
Yeah. So a gait speed, and this is important when we go through the short physical performance battery, is it's done a little bit differently. But there's a ramp up and there's a deceleration phase. Really important thing. You won't forget. Gait speed is like a midstream urine sample. Gait speed has been called the sixth vital sign. It can predict things like hospitalization rate, independence with activities of daily living, if they're able to thrive and interact socially in the environment. Like, it's one thing to get someone home and like that's cool, but can they go to their bridge game? Can they go to church? Can they go to dinner to their favorite restaurant? We can check a gait speed and know all those things. Their risk of going to the hospital. That's pretty crazy, guys, and it doesn't take that long to test. We're gonna go through some more outcome measures. Another option for gait speed, growing research in this area, is gait speed reserve. Anybody heard of this one? So gait speed reserve, you can think about that physical reserve, but for walking speed. So there's their normal self-selected pace minus how fast they can go, like their top end. Like our patients when we try to test them for the tug, and you're like, this is gonna predict your risk of falls. And then you sit them down and they're like, boom, they're walking faster than they've ever walked before, and they sit down. That speed versus their normally selected can give us a lot of great information. Also, backwards walking gait speed. These things are all growing in the research. Really very practical ways to get good information on our patients. Timed up and go. What do we usually use the timed up and go for? Crickets. Falls risk, yes. That's what we typically use it for, right? Did you know it can predict congestive heart failure, a heart attack, mortality, how long our patient's gonna be alive? Pretty crazy stuff. You wanna keep in mind that the tug, the way it's described, varies depending on the study you're looking for. So based on the information you're trying to use the test for, you may wanna dig into the methods a little bit and figure that out. Whether they're starting with their back against the chair, whether you get to tell them go or they say go, if they're going a cone or a taped line, like there's lots of variations on the study. So keep that in mind if you're gonna be using these measures to predict those things. How about grip strength? Anybody checking grip strength? Yeah. What do we usually test grip strength for? Huh? Ace, right back there. Clearly familiar with the study. So we can get an idea of a patient's overall physical well-being from just a grip strength. So it can predict a lot of the same things. There was a news article that came out talking about your grip strength can indicate your longevity or your mortality, like how strong your grip was. And man, Amazon, all the grip stuff was just going through the roof. People thought that if they just made their grip stronger, they were gonna live longer, right? And that's not the point. The point is your overall physical ability and that correlation to your reserve, right? How robust of a human being you are. Not if you sit in your recliner and work your grip. Can predict cancer with a grip strength measurement. This was a really high quality study, over 100,000 people in it. High predictive value. super cheap. You can get them for 40 bucks, right? A measure like this is really helpful for people with, I don't know, that high irritability patient. If you're suspicious, part of their problem is they're not moving and they're not strong and they're not robust, check a grip strength, okay? It can be really easy to leverage a tool like that. This is a great example of poor government branding. STEADY, what's it stand for? Stopping elderly accidents, deaths, and injury. Boy, do I want to pick that tool up, right? But the STEADY is being taught to our professionals in the medical field, physicians assistants, and what it is, it actually has a lot of great screening tools. A lot of the tools you're using, 5 times sit to stand, single leg balance, screening tools for general practitioners to be able to identify if their patients are at risk and who to send them to. Do they go to an ENT for vestibular? Does this look like this is a blood pressure issue? And information on orthostatics? Do they need to go to physical therapy? We hope, right? But this tool has got so many great resources in like patient-friendly formats that you can like print this stuff off and like hang it up. But just so that we're talking the same language, and you know, this stuff is being taught in medical school now. A lot of programs. So we're getting help. People are coming on board with us in this area. So in general, we get an idea of where we think our patients' deficits are, what goals they're trying to reach, figure out what's their barrier. Based on that barrier, we want to select a tool for that, right? So as we're looking through this is just some like basic, a general screen that's got balance, it's got sit to stand, got gait speed, short physical performance battery. We're going to go through that. Strength, we got one way to look at strength, right, from the deadlift using an AMRAP set. We're going to cover that more in exercise prescription. But different balance tests. There are all kinds of balance tests in there. We're going to help you dial in which one you should use based on the deficits your patient has. Also some endurance measures. Has anyone in here done home health? No? No home healthers? Y'all are breaking my heart. If you have a cramped clinic like I practice in, even if you don't do home health, 2-minute step test can give you a lot of great information without having room. Because we hear that a lot with people that are like, well, I would use the 6-minute walk test, but where am I going to do that in a busy clinic? Well, if you need an endurance-based measure, the 2-minute step test has done a really good job of correlating and giving even normative values based on age for our patients for endurance. But make sure your barrier matches your objective measure is really the big takeaway. So we've got all this great information, very powerful information. We're equipped with lots of information on our patient, what these tools have taught us. We're looking into our crystal ball, and the picture does not look very good. So what do we tell our patients? Their tug should be 14 seconds. They did it in 48. Man, you're really high risk of falling. If you fall, you could break your hip. If you break your hip, you might die in a year. Does that build trust and rapport? Did I do that once? Yes. I'm ashamed to tell you I did do that once because I thought I was being really smart and helpful to get their attention. That is very damaging. It drives a lot of fear beliefs. Scares our patients to death. We know what fear does to them, right? We're seeing a window into that. We want to make sure we share the good news. That patient that crushed her 5 times sit to stand, you better believe we celebrated. I was like, most of your peers, like, a lot of them can't even complete the test with their arms across their chest. And you crushed it. You were doing very well in this area. How many times do you think our medical providers, our colleagues, are sharing positive information about our older adult patients? What do we spend our time on? The stuff that sucks, right? Share the good news. Tell them where they're doing well. Build their confidence. Build that trust. Build that therapeutic alliance. These things are going to set you apart in a big way. Avoid the non-diabetic idiopathic peripheral neuropathy. Your feet don't feel as good. They can't feel as well. So you can imagine that's hurting your balance. The good news is we've got 3 other balance systems I can help you work on. There's lots of redundancy in the body. It's very resilient. We can help you compensate for that. Which one sounds like the provider you want to go to? Right? You can be that provider. These little things will set you up for success. Great quote. We've talked about it before. We're going to talk about it again. It's really important. Beliefs and expectations are the foundation on which outcomes are built. Beliefs and expectations are the foundations on which aging is experienced, right? Christina was talking about the studies. Risk of cardiovascular disease, getting dementia based on what they believed was going to happen. Not their physical body, not their performance, what they believed was going to happen. We want to be part of the solution, not the problem here. So, this is great. If you've been to an ICE course, not rubbing it in, but you probably already have heard about Build the Bike. We like to talk about building the bike. When we say build the bike, we're talking about leveraging that test retest and showing our patients the path to success, the path to the success they want, right? Does anyone in here do any cycling? Own a bicycle? Did you get to have the experience of going into a bike shop to get your bike? No? Yes? No? Okay. Some people have, yeah, maybe. So bike shops have changed a lot. When I was a kid, like you went to Walmart, you grabbed a bike, you took it home. Bike shops now, like it's an experience. It smells vaguely like smoke, even though no one's supposed to be smoking. You can get your favorite beer on draft. They probably have a really cool coffee shop. There's a dude that looks like way too cool that I would never talk to in my life, that probably knows all kinds of bands I wish I was listening to. Like, it's a really cool place. Like, it's an experience. You walk in and you see bikes you've never seen before. There are bikes in there with tires this big. You're like, what in the world is that for? And then you walk over here and there are bikes with tires this little. You're like, I'm gonna pop those tires, right? There is all this variety. And then you walk in, you're like, oh my gosh, like, how am I gonna make a decision? Like, I think I'm gonna walk back out. And then someone talks to you and they're like, hey man, what can I help you with? You're like, well, I'm looking for a bike. Okay, cool. What do you want to do with it? Where are you going to take it? How often are you going to ride? How much experience do you have riding? Are you going to take this off-road? Are you going to go cross-country? Are you like going from the East Coast to the West Coast on this thing? Because I know some really comfortable seats for you. Are you going to be mountain climbing? Are you going to be downhill racing? Like, he asked you questions you didn't even know existed, right? Just to get to know you and what you want out of this experience. You bought the bike, so what? Why did you buy the bike? So it really gets in at the experience piece. By the time he's asked you 100 questions, knows everything about you, he said, I know exactly what you need. I've got just the thing for you. I've got it in your size. I'm gonna roll this thing out for you, and we're gonna fit it just to you. And you're like, dude, this is cool. I thought I was just gonna like take this thing off the shelf and like hope it worked, right? And instead, he says, all right, it's adjusted. Do you want to take it for a spin? And you're like, are you kidding me? You're gonna let me on this thing? I'm like, yeah, go take it for a spin, see if it works. That is building the bike for our patients, right? Do they want an off the shelf or do they want an experience? Have you provided the value? Ask the right questions. Are you giving a tailored solution to their specific problem? Not everyone else that looks and acts like them, but to their problem, right? That's build the bike. That's build the bike. So if we can make meaningful change on their problem once we've identified it, man, they're sold, they're in. You accidentally screw some stuff up on your dosage and make it a little bit too heavy and they get sore, or a little bit too light and they're like, man, that was really easy. They're still gonna come back because you listened, right? Maybe for the first time for them. They've never had anyone really listen. Super important stuff. So, all this boils down to this. You can treat pain, you can treat balance, but please keep in mind this patient 30 years from now. If you can get them in some type of fitness routine, you can change the trajectory of the rest of their life. They could go from 2 to 3 years to 10 years, 10 vibrant years. Like that's what we all want, right? If we're gonna age, we wanna do it well. And when it's time to go, we want to go quick, right? We don't wanna be sick for a long time. Barely get well and then get sick again. The more robust we can make our patients, the more we can introduce them to the land of fitness, the better off they're gonna be in the long term. Building expectations for our patients that are reasonable. Not what do they want to hear, what's the reality? A lot of them will be refreshed. I think a lot of times we're really hesitant to say, you've been sick a lot, maybe for like the last decade. If you want to be able to play with your grandkids and take that road trip out west, you're probably going to have to be consistent in some type of routine for 6 months. It takes time to build real strength. We got to build habits of things that are important, that are fun, with people you like, that are going to hold you accountable. I'm going to be this part of the journey. I'm going to help you find resources of places you can go that you enjoy, so that after we're done, you just keep climbing that mountain. You get to that goal. I'm this part. What you really want is going to take this. They will value that. They will value that. So their homework can't be one of those print-offs, right? We can't provide that experience and say, hey, this works for all my people after ankle sprains. It looks like this, right? There is a great PT on Ice episode from Alex Germano, one of our other teaching assistants, talking about very potent exercise programs for older adults. The programming side of those, some fun, interesting ideas. We're going to be sharing those with you along the whole weekend too. So takeaways. We don't change pain, we change lives. I've done this wrong before. That's why I get excited to come up here on the weekends and talk to you guys about it, because I've had that gut visceral reaction when I saw a patient I saw 8 years ago come back to me and realize they are no longer a robust human being. They're deconditioned, they're scared, they don't have confidence in their body anymore. I had the opportunity to set them up for success, and instead I was like, I'm good at my job. I'll get them feeling better, and 4 visits and discharge, see you later. Right? Missed opportunity. When you see those people come back, man, it's painful. It's painful. So be a guide to the land of fitness. You can do that after you've built the bike. We've chosen screens that match up with what they told us to test our hypothesis. Cool. Questions? Yes.
So one of the things, like asking that, like, what does success look like for you?
Yes.
That is something that I've worked on building into my subjective. And the
Awesome.
thing that I have run into consistently is I just want the pain to go away. So
And-
how do you balance that, the answer that they're giving you, with that first point on the last slide of, like, we don't treat pain,
Correct.
we treat function?
What would they do differently if they had pain? Sometimes that's multiple visits, right? They're so focused on the pain, it can be really difficult. I don't want to paint a picture of this that it's really easy to do and that you can always nail it on the first day. But they're going to live their life differently because of the pain. If they weren't, then pain is pain. Like, if we can get you on enough narcotics, your pain will go away eventually. But like, what do you want to be able to do with it? It can be hard, but like just digging in. It's like, okay, if I could wave the magic wand, like I've used that one a lot recently, which sounds kind of silly, but can be really helpful to say like, hey, what can I do? What would you do differently? The pain's gone, so what? It can be hard, but yeah. Good. Other questions? Yes?
Explain how you use the grip strength as part of your screening process. Is that information you're gathering for yourself to categorize that they may be in that higher risk?
Correct.
Or just kind of noting that?
Yeah, exactly. So in the screening of your patients, subjective, you start getting an idea that they're deconditioned, they're not moving, or they have high irritability of symptoms. That screen is giving you an idea of how robust that human being is. How close are they to all these chronic conditions that maybe aren't on the chart yet? Right, thinking about frailty. Absolutely. Yes.
Sorry, just know too that grip strength isn't a very good pre-post intervention outcome radius for a lot of like epidemiological data sets to stratify risk, but you're not gonna get a statistically significant increase in grip strength pre-post most of the time.
That's a great point. Not something you want to use for your asterisk sign,
Yes.
but something you'll use as a screening tool to rule in or rule out frailty or that frailty spectrum. Anything else? All right, y'all crushed it. Nice work. So this is a big list of outcome measures. There's lots of stuff on there. We're gonna go through some key ones and break it down for you, okay? So everything we do, we're gonna like go through looking from the perspective of Anna, Doris, and Bill. We wanna get an idea of the patient that looks like Anna, who's independent, goes to pickleball tournaments, right? Versus Bill, who just came out of the hospital and has a great relationship with you, but should probably be in home health. But he's getting rolled in the wheelchair, and you're gonna do your first transfer since you were in PT school. Bill's gonna roll in. Who's had a Bill roll in? And you're like, oh crap, I've not done this stuff for a while. We're gonna help you for that moment, okay? And then Doris is somewhere in the middle. Maybe she needs a little bit of help steadying, or maybe she needs a little boost to get up, but then she's up on her feet moving. Looking at these outcome measures, there are some that you can typically do, like grip strength, if it's valuable. If Anna tells me I'm playing pickleball tournaments, I'm probably not gonna do a grip strength. If Anna has all the capacity to be doing pickleball tournaments and she's choosing a much lower level activity, then I might do a grip strength, right? But there is a level of testing that you can do for all of these. Balance on Bill, looking at his function in sitting test. How well can he control his trunk in multiple directions? What are those transfers gonna look like? Versus Anna, you might take her through the mini best test. Has anyone done that one? Couple. The rest of you guys, we're gonna have some fun. It's good. It's a great test. It tests some parts of balance that we don't see anywhere else in most of the outcome measures. So short physical performance battery. I always get the P's and the B's confused, but I got it for you guys today. Very helpful. Some electronic medical records have this built in. When I was in home health, this was built in and it would calculate the score for you, which was super handy. Very well researched outcome study. It looks at balance in 3 different positions. It looks at a sit to stand, and it looks at a gait speed. So it's a nice general screening measure we're gonna cover together. Cool things it can predict: physical mobility, disability, mortality, all those things. We can get an idea from just running the screen that will take you about 3 minutes to do, okay? Minimally clinically important difference is only 1 point. You move the needle 1 point, you have done something significant for that patient. That can make it a really handy tool as well. So let's go ahead and stand up and let's practice. So you guys that are against the wall, you may need to move out a little bit so you've got some room. So go ahead and explore the space over here. So what I'm gonna have you do, I'm gonna read some of these instructions because they're quite specific and they're a little bit different from some of the balance measures you've done in the past. So I'm gonna have you put your feet side by side. You may use your arms, bend your knees, or move your body to maintain your balance. But do not move your feet. You'll also notice in the instructions you can help get them into position. It's kind of interesting, right? All right, we're gonna have you guys balance for 10 seconds, but pretend you've got really severe knee OA and you can't bear much weight on it. Go. Come on, guys, like you mean it. Everything can move. All right, you still crushed it. Good job. Okay. So you're going for 10 seconds. Then we've got semi-tandem. Lots of debate on semi-tandem, depending on the study you're looking at. Semi-tandem can be lots of things. Semi-tandem is defined as big toe is touching the heel. If these were my feet, this is the position you should be in. Not separated, not foot at the arch. Let's go ahead and balance. Good. Doing pretty good. No one had Irish coffee this morning, I see. Still up on their feet. Good. Good job. So once again, they can move, can't move their feet. You can help put them in position. Then we've got tandem stance, heel in front of the toe. No separation between the feet. Heel should be touching the toe, and go. Did your all's knees get better? What's going on? There's no movement. Good, there you go. Ham it up. Good. Good job. So here's some of your scoring. Yes?
When you change your feet, change to the other way, then people lose their balance when they're changing like directions. Is that, you mark that somewhere, or is that?
Repeat your question. I don't understand.
Say you're doing tandem, but then you tell them to move with your left foot in front, and then when they're moving in that transition, change their foot to the other, that's when they lose their balance. Not standing there, but
Correct.
the movement of getting there.
That's a weakness of this test because you get to help them get into position, right? And on this one, they just select one, so you don't actually test both. Some of the other ones, they do ask you to check both, and we're gonna look at some other ones that look at both. But yeah, that's a limitation. That gives you good information though, right?
Yeah.
I was gonna say, if you're having that person who's losing their balance in those positions, guess what my intervention's gonna look like? Lateral stepping strategies, right? Like looking at crossing over steps. Can you cross in front? Can you cross behind? Can you have a perturbation come laterally? Because if they're having trouble with that crossover, we tend to focus so much in the sagittal plane. But what happens if their deficit isn't in the, like, for me, if they could get into a tandem stance in the sagittal plane, but they can't even have any sort of dynamic stepping strategy in the lateral plane, that tells me that my interventions for balance are gonna really focus in that direction.
Yeah. Great information. Great thoughts there. Thank you.
So they could hold on to something to get into position too?
Yeah.
Because it-
I'll hold on to you.
Yeah.
Like you can help them get into position or they can hang on to something. Good, so you're gonna look at the scoring. The first two are simple and then it starts splitting up. 0, 1, 2 points. It's like, great. My brain's already starting to check out. And then the scoring gets even more confusing when we start talking about gait speed and how long it took them. There's good news. There's an app for that, okay? It's a SPPB calculator. It's free and it will calculate your score. All you have to do is put in the number and it will give you the raw score. If you don't have this built into your EMR, I would definitely look at that. So gait speed, you can either do a 3 meter or a 4 meter test. But let's look at the instructions. Now I'm gonna observe how you walk, how you normally walk. If you use a cane or other walking aid and feel you need it to walk a short distance, then you may use it. This is our walking course. I want you to walk to the other end of the course at your usual speed, just as you're walking down the street. You're gonna notice that they're gonna start when you say go, and you're gonna start the time. How does this relate to a good midstream urine sample? No go, right? So that gait speed measurement, we cannot sub this in. We can't say, oh, I already got a gait speed in the SPPB because we didn't do it properly. And that's not how the research was done, that we can leverage those outcomes. So just something to be aware of. It's a little different with the scoring. I know we like to be efficient and save time, but it does not quite work that way. Good. So we've got our gait speed there, pretty straightforward. Measuring it out, start, stop at their usual speed, okay? Then we've got repeated chair stands. Let's do this one together, because you've not done any of these yet. We're gonna start in sitting, and we're gonna have you cross your arms across your chest. And then when do we count this one? When you stand. Every time your butt comes up. So the chair rise test is actually different than the 5 times sit to stand. We'll talk about it more after your 5. Go. So with these outcome measures, because there are so many of them and they're so similar, it's easy to get those like a little bit mixed up. But on this one, you start from sitting, you tell them when to say go, and you count every time they stand. So it's how long it takes for them to stand 5 times. So 1, 2, when they stand the 5th time, the time stops. Cool, so a little bit different. All right, before you guys fall asleep, we're gonna break all the rules on the tug. The tug can do lots of things very well if we do it properly. We're not gonna do that today. We're gonna have some fun. We've got a prize for you guys, but it's only for the fastest tugger. Timed up and go. The things we need, we have got chairs set up here. I need one person in a chair, and I need someone with a way to time them. So if you're gonna use your phone, use your phone. What we're gonna